Hello, my name is Ryan Jackson. I'm a head and neck surgeon at Washington University in St. Louis, and I'm going to talk to you today through the American Head and Neck Society Torres Fellows Didactics Program on the management of the contralateral neck and oropharyngeal squamous cell carcinoma. For disclosures, I'm a consultant for Intuitive Surgical. Regarding the nodal drainage basin for the oropharynx, it typically consists of the jugular chain, including levels 2, 3, and 4 neck dissections. Contralateral nodal disease is involved in approximately 2 to 24% of patients with oropharyngeal cancer. And people have described this to increase in patients with T4 disease, tumors that involve the midline, and patients with enlarged or multiple involved nodes on the ipsilateral side have a higher risk of contralateral nodal disease spread. HPV status should not change the pattern of spread of the lymphatics. Anatomy is anatomy. So the oropharynx should spread to their predictive drainage basins, but HPV status may change the incidence of nodal disease. Looking at a paper produced by Peter Zigulewski, he found that 24% of patients that undergo bilateral neck dissection in his study cohort had contralateral nodal metastases, and this increased in patients with enlarged tumors involving clinical T4s and those with AJCC stage 7 N2A disease, so patients with 3 centimeter or larger nodes or multiple nodes. And he came out with a schematic here saying that patients with clinical N0 or N1 disease did not necessarily have contralateral nodal metastasis risk, especially if the tumor was not involving the midline. The tumor site itself was not predictive. So in their study, they did not have any higher risk if the patient had a base of tongue versus a tonsil versus a palate. We looked at the risk and rate of contralateral nodal disease in patients with oropharynx cancer in a cohort of base of tongue only patients, because our theory is that the closer to midline the tumor is, the higher the likelihood of contralateral nodal disease. So we looked at base of tongue only patients and those patients that had bilateral neck dissections. So all these patients had clinically N0 contralateral neck disease, but still had an elective neck dissection. And we found that 21% of these patients did in fact have occult nodal disease in the contralateral neck, despite having negative clinical examinations, negative PET scans, and everything else. This risk did increase as tumor approached or crossed midline. You can see here, but when we looked at distance to midline, trying to break it down by a metric of millimeters or centimeters, I think our study was just underpowered to find any good cutoff, whether 1 centimeter or 5 millimeters from midline is what we should be using as a cutoff. Knowing the risk and the rate of contralateral nodal disease and when to perform elective treatment, there are multiple types of management of the contralateral neck. One is to observe it. One is to treat it therapeutically if there is positive clinical nodal disease, and that could include a neck dissection. It could include radiation therapy or both. And then if it's a clinically N0 neck, we can electively treat that, and that's with either a neck dissection or radiation therapy. So the question of which one to choose, elective neck dissection versus elective neck radiation, it comes down to risks and benefits. The benefits of doing a neck dissection versus radiation therapy is to avoid bilateral neck irradiation, which irradiates the constrictor muscles on both sides of the pharynx, bilateral salivary gland irradiation, significant muscle fibrosis, and lymphedema. It also gives us accurate pathologic staging. The risks of doing a neck dissection, though, is largely related to the vasculature and the cranial nerves. And in our experience, cranial nerve 11 is the most at risk with shoulder dysfunction. Another risk is that patients may still get radiation. If you see a patient in an academic institution and they get their radiation in a community setting, the radiation oncologist may not be comfortable sparing radiation to that negative neck, even if it's pathologically negative. On the other hand, you may still need radiation if you do find occult contralateral nodal disease. And in our study, it was approximately, just over 20%. So we had a prospective trial looking at unilateral versus bilateral IMRT for patients treated with tonsil cancer, so a lateralized oropharynx cancer. 154 patients with lateralized oropharynx cancer into the tonsil. with a follow-up of 5.5 years. These patients were spared bilateral IMRT versus given bilateral IMRT, and they found no difference in recurrence events in the contralateral neck for patients with tonsil cancers. So the overall oncologic outcomes were similar, but you can see in figure A and B here that there was improved quality of life for the patients that had ipsilateral IMRT only and those that were spared the contralateral neck. This is a good study from the Netherlands, looking at a cohort of the literature, 11 articles and over 1,000 patients who underwent ipsilateral primary radiation alone with oropharynx cancer. They only had a 2.4% contralateral regional failure rate. It increased if it was midline tumors. So tumors that approached or crossed midline had a 12.1% risk compared to those if the midline was free of only 1.7%. So the theme here is that as tumors approach or cross midline, there's an increased risk of nodal disease. This led to another study looking at bilateral versus ipsilateral adjuvant radiotherapy in patients with cancer of unknown primaries. And they looked at 76 patients with cancer of unknown primary of the head and neck treated with surgery who had radiation therapy in an adjuvant setting. And these patients either had ipsilateral or bilateral neck radiation therapy. There was no difference in survival in the patients that received bilateral radiation therapy versus those that received ipsilateral radiation therapy. And that's patients with only ipsilateral clinical nodal disease. So this excluded patients that had bilateral nodal disease. Here's a prospective trial that we performed looking at eliminating postoperative radiation therapy in the pathologic node negative neck. This was not just oropharynx cancer patients. This included other sites as well, but oropharynx comprised approximately half of our patient load. We had a median of 4.5 years of follow-up. So we had pretty good follow-up to determine any oncologic outcomes. In this study, we found there was a 97% regional control rate. Only 2 patients failed in the contralateral pathologically N0 neck. So if a patient had a pathologic N0 neck on neck dissection, they were spared radiation on this trial. Only 2 patients failed in that neck out of the whole cohort. The interesting part is both of those patients also failed at the primary site. So nobody had an isolated failure in the neck. And this could be due to a couple of reasons. Either a node was missed and they had just a surgical and radiation failure, or the primary recurrence was driving that contralateral occult met to that neck, secondary to altered lymphatics. Here are recommendations from the ASCO clinical practice guidelines. These guidelines looked at both oral cavity and oropharynx cancer guidelines for management of both necks. So breaking down just the oropharynx, they recommended that lateralized oropharynx cancers treated with surgery should get at least an ipsilateral neck dissection levels 2 through 4. And to determine quality of the neck dissection, they should try to achieve at least 18 nodes removed. They also recommended that the ligation of at-risk vessels occur. So that's either the lingual or the facial artery, or sometimes the superior thyroid artery. That's out of the scope of this talk, but it was one of their recommendations. And their level of evidence for this was moderate. Their second point regarding the contralateral neck is that midline oropharynx cancers treated with surgery should undergo bilateral neck dissections levels 2 through 4 or a contralateral elective neck irradiation. Level of evidence for this again was moderate. So my final thoughts are contralateral nodal disease increases as tumors approach or cross midline. So lateralized tonsil cancers have a very, very small risk of a contralateral occult nodal disease. If it extends onto the palate and approaches midline, or if it extends down to the base of tongue and approaches midline, the risk of a contralateral nodal metastasis increases. The extent of the ipsilateral nodal disease may increase the risk of occult contralateral disease. So if a patient has 3 or 4 ipsilateral nodes, that patient has a higher risk of a contralateral nodal metastasis than somebody with 1 2-centimeter node in the ipsilateral side. Lateralized oropharyngeal tumors can likely have ipsilateral treatment only based on this data. then you can spare the contralateral neck dissection and you can spare the contralateral neck irradiation for patients with isolated tonsil cancers that do not approach midline. Midline oropharyngeal tumors do need elective contralateral nodal treatment, whether that's neck dissection or radiation therapy. Thank you, and please let us know if you have any questions. You can reach out to me at any time. My email is jackson.ryan@wustl.edu, and I am happy to answer any questions.